Thanks. I'm delighted that somebody actually read the quiz. I hope lots of you had a look at it. I suppose that was just something to maybe get you thinking, and I'll run through it a little bit. So anticoagulation is an evolving and a confusing area, and it's particularly in our patient population, it really is devoid of clear guidance. So these are guidelines, guidance. Essentially, we're just trying to raise awareness, because I think a lot of the time anticoagulation medications aren't at the forefront of people's minds when they're reviewing patients, and we need to get a little bit better at doing that. And also there are certain procedures and guidance that you definitely should be following in terms of advice, so we just want to bring that forward. So that's what this is about. So sometimes we have a lack of knowledge, or maybe the outdated knowledge, so this we hope to update you on it. Uncertainty as to where to look for guidance. There actually are, well, we've brought out some resources which will soon be available in a ward area near you, but also online, and just to know when to escalate and when to seek help. But really it's just getting anticoagulation on our radars a little bit more as clinicians. So, this is a recognised area of risk, and you know, every so often there are incidents, and that always prompts us to look at our practice as well. So the working group came together as myself, Emer O'Dwyer, Stephen Higgins, and even one of our SBRs whose surname I can never pronounce, and Carol Lynham from the nursing perspective, and we came through the DTC and basically pulled this guidance together over the last number of months. So here's some of the quiz questions that you might have seen going down that I invented. So 2 of these are not DOACs. Do you know which? Up here. Which of the following can reverse bleeding in a patient on a DOAC? You know, is there a reversal agent, or is there none at all? Will it be reversed by transfusion, by idarucizumab, by protamine, or by vitamin K? So just get yourself thinking as you go through, and would you know the answers? Your patient with cancer has an acute PE. Should they be prescribed now a DOAC, these new and novel agents, warfarin, or low molecular weight heparin? 3 months down the line gets another one, but he's on the anticoagulant. What do you do in that case? And then a few other questions specifically. He gets brain mets. Is it safe to continue on treatment? A scan shows incidental findings of clots. Do you treat that, or do you just ignore that because he's not symptomatic? So there is actually guidance around some of this. So like we said, guidance rather than a policy or an SOP, and really we're here to educate, and I'm delighted that so many of you have come in for this this morning, so thank you for that. Fiona Lawler in the library was a great help to us in terms of just looking at what literature was there. So really we just gathered everything together. Here's just a few screenshots of the tables of the stuff that we pulled, and I suppose we didn't formally go through a mad adapt process or anything like that, but really just to know that we had a sense of everything there, and pulled a few of the chief guidelines together. And essentially our work was done for us in some ways, and even a couple of months back presented some of this at Grand Rounds, if any of you were there. So the 3 main guidelines that we drew on were chest. I think that's a 2015 guideline. The British Journal of Haematology also has recent guidelines. It's either 2015 or 16. And then the JCO has guidance a number of years back, and then they updated it in 2016, I think republished in just 2016. So they're all helpful. The guidance deviates a little bit. So when you come to, if you're ever sitting down looking at it, we do have our guidance referenced, so you can see exactly where we're coming from on things. But even the fact that they slightly disagree in some areas just goes to show the dearth of evidence that is there. So essentially the resources that we've developed are, I'm going to leave the screen, Nicholas. Poster. Okay. A poster that we're hoping to have up in clinical areas, so that just pulls the main evidence together. There's 3 gone over to Blackrock already, and they'll be going out to the wards and home care and day hospice in the next 12. This is guidance for palliative care patients, so it's not, we haven't, phase 2 might be developing it for extended care care, but at the moment we're just defining that population, but certainly it would be a resource. Secondly, then we've pulled into a booklet, and I'll make these available, just really an A4 version of everything together. In terms of what Ciara is going to present on the actual pharmacology bit of it, there's tables of varying depth going into the DOACs and warfarin and all the rest of it. And then we love our stickers. So stickers to go onto the charts if a patient is on an anticoagulant, okay? And I think we'd agreed that it would be on the inside cover where you're noting patients' allergies and things there, but really the more highlighted it is, the better, okay? So those stickers will be rolled out, and it's the responsibility of everyone looking after a patient to put a sticker on if you determine that they're on an anticoagulant. It may have been missed by the person before. Okay, so the guidance, the key areas are general guidance. Evan's going to talk us through that. Basic information on the anticoagulants themselves, management of VTE, management of bleeding, thrombo prophylaxis, and then really where, when to seek help and escalate, and we'll run through the resources there. Okay, thanks.
Thank you. So this is meant to be a very usable guide for doctors and nurses who are looking after patients and who may be on an anticoagulant. It's not an exhaustive list for what to do when somebody is on it. So when somebody is on a DOAC or on warfarin or on low molecular weight heparin, but it's supposed to help us kind of trigger thoughts of what we should be looking for. Just because something isn't on this doesn't mean you wouldn't think about it as well. So it's just a kind of a thought process and a trigger process, and there's no time limit for when this is used, so it's not that this should be used at admission and it's not looked at again. It's understanding that patients, especially palliative care patients, have a changing clinical state, and that it's something that we should be thinking about. This guide can be used in the community, so in the community when patients are being admitted, when they're being reviewed, or when something is changing in their clinical condition. It's, I suppose, in the community before, when we had a lot of cancer patients, the main patients that we would have seen were cancer patients who were on low molecular weight heparin for either a DVT or a PE. But we have to acknowledge that our patient population is changing, and especially with our increase in non-malignant patients who may be on anticoagulation therapy for atrial fibrillation, for example. We're not saying take over responsibility of anticoagulation in this patient, but at the same time it will be irresponsible of us as doctors and nurses not to just be aware that they're on these medications. And I suppose in the community, for things like atrial fibrillation, patients are likely to be mobile and have a slightly longer prognosis than, for example, patients in an inpatient unit. And so they may be the patients who are more likely to get benefit from anticoagulation for atrial fibrillation. And so we would expect that we will be seeing more of that. And this can also be used in the inpatient unit setting when patients are being admitted, or when something is changing with a patient, or just when you're reviewing a patient on a ward round, in day hospice and in the acute hospital setting. I suppose as well, when we were thinking about this, we were thinking that the disease trajectory of our patients change, and in palliative care very often that's a deterioration. So there's things that we need when a patient is changing. You're thinking about things like that may affect their anticoagulation status, so marrow failure, renal dysfunction, liver dysfunction. Is the patient becoming less mobile? Are they at a falls risk? So all the time in the back of our head we're trying to balance the benefit and burden of anticoagulation for these patients. So I'm just going to take you through the thought process that we had and through this part of the guideline. So the first thing is just to recognise that a patient is on an anticoagulant drug. So there's a lot of new drugs, and there's people are flicking in between using two names for drugs, especially the new DOACs. So just naming them and recognising them, and this is where the sticker comes in as well. So that we first of all recognise that a patient is on an anticoagulation agent. And the next part then is so we put antiplatelets in there as well, because they're not an anticoagulation agent, but it's also important. They do affect how a patient will bleed, and that's important as well. review the indication and duration for an anticoagulation agent. So I suppose we don't expect everybody to remember all the exact numbers off the top of our head, but if you're going through somebody and you notice you're on low molecular weight heparin, you can just ask, why are you on that? You know, is it for a clot? Is it that you were on warfarin for atrial fibrillation, but they felt that you'd be safer on low molecular weight heparin? Do you have do you not have cancer and you're on a DOAC for atrial fibrillation? So it's just another little piece just to think about, and the duration of it. So I suppose for atrial, we're very used to people being on anticoagulation therapy indefinitely. So if you've had a clot in cancer, you're supposed to be on it indefinitely until there's a reason why you shouldn't be on it. But there's some people who are on it for just a short defined amount of time, and that should also be considered. You know, for example, if you've had a clot associated with a PICC line, you know, you're only supposed to be on treatment for 6 weeks or so. Now most people it would be indefinite, but it's just to think about duration. The indication for indefinite anticoagulation is not called lifelong. It's called indefinite, and it's called indefinite because again you're looking at a balance. So at some point it becomes appropriate to stop it. So it's not until the patient is right at the end of their life. The history, so then as you're talking to the patient, just things that you might be looking at in the history, you know, any recent bleeding events. And I suppose one thing that came up was that we were kind of thinking, well, our doctors and nurses going to think now that we're expecting to take over the role of monitoring anticoagulation. We're not saying that, but what we are saying is that, for example, if you have a patient who's on 3 antihypertensive agents, it's appropriate to ask that patient, do you feel lightheaded when you stand up? You know, we do have a responsibility to review medication, and so just checking in any bleeding events, any change in the history that makes bleeding more likely. Another thing to ask patients perhaps as well is you know, who's monitoring their agents. So there should be a designated health professional assigned, the prescriber generally, for an anticoagulation therapy, and just asking the patient, because as well that's going to trigger, they say, oh well, the GP says I'm supposed to get a kidney test every so often, but I haven't really been back to do it. And you say, well actually, you know, you have to, you know, you're on a DOAC, you should be getting your renal profile checked every so often. And then I suppose on examination, just be aware that if you see any signs of bleeding, any signs of bruising, that just might be a trigger. It mightn't say stop anticoagulation therapy in anybody with bruising, but it's just to think about, is this still appropriate therapy? So then there's a couple of laboratory investigations. Now, we are not saying that it is appropriate to do this in every single one of our patients all the time, but again, if you're thinking about reviewing anticoagulation therapy in a patient, these are things you might be looking at. So we've just given a little bit of guidance for what you might be looking at. So very simple things like doing an FBC, checking has there been a recent big drop in the hemoglobin, if there's been a question about an occult bleed, looking at a patient's platelets, because if they're becoming thrombocytopenic as their disease is progressing, it might be appropriate to then consider stopping their treatment. And a coagulation profile. As patients become more sick, they may have a tendency towards a coagulopathy, and so they may be what's called auto-anticoagulating. So their liver isn't making the proteins that you need to form your clotting cascade. And so if this is happening, if this is happening in your liver, you don't want to be on an anticoagulant as well. So again, that might be a trigger that it's time to stop one. Your liver profile, if liver disease is suspected, it may not be affecting your clotting cascade at this point, but it also may be a trigger that if this person has liver disease, at some point they're not going to be, you know, able to make their clotting factors properly. So maybe some point down the line, so I might put 2 months time review anticoagulant therapy. And then your renal profile. So this is important because a lot of the new DOACs, their dose is dependent on your renal function. So they should be getting their renal profile checked to make sure it's still appropriate. Your low molecular weight heparin dose can change if you have an impaired renal function. And in high uremic states, your platelets don't always stick together as well. So they're just things that you might consider are appropriate, but not. This is not prescriptive for every single one of our patients. Clinical judgment has to be taken into account. So after all that information, then you're just trying to assess, is anticoagulation therapy appropriate? You're trying to decide, what's the balance and what's the benefit of being on it. And so, again, sometimes some of this just involves thinking about what the benefit is. So, just as an example, in a patient with atrial fibrillation who has a CHA2DS2-VASc score of 0, 1 and 2, your annual risk of an ischemic stroke is 0.6, 1.2 and 2.2%. So in a non-cancer patient who has atrial fibrillation, who's not on anticoagulant therapy, their annual risk of a stroke is 2.2%. Not insignificant, but it's not as massive as people sometimes think it is. And that's important to remember, because people worry, we're stopping the warfarin, they're going to get a stroke. Well, their annual risk of a stroke is 2.2%. Their life expectancy might be 6 or 3 months' time, and actually their risk of a massive bleed is higher. And so knowing those figures, or knowing that you can go to the literature and look for those figures, is important. There's a lot of figures available. People worry about people with mitral valves, things like that. So we don't expect everybody to know all the answers, but what's important is to think about it and then to ask somebody or to look up literature where there may be answers. There are some things that can help if it is atrial fibrillation, and we put this in because we just feel that there's a growing non-malignant population. Things like the CHA2DS2-VASc score and the HAS-BLED score. So for people who aren't familiar with those, the CHA2DS2-VASc score is a score that helps you define your risk of a stroke in atrial fibrillation over a year, and your HAS-BLED score is your risk of bleeding, and that can help in your clinical judgment for balancing whether anticoagulation therapy is appropriate. This is a guide, and this isn't, an absolute prescriptive what you should be doing. And that's me.
Good morning. My name is Ciara. I'm one of the pharmacists here in the hospice. Emer O'Dwyer was part of the working group, but as she's currently on maternity leave, she can't be here today. So I'm just going to give a quick summary of the anticoagulant medications that we come across ordinarily. So this will be Warfarin, our low molecular weight heparins, and the newer agents, the NOACs. The old reliable Warfarin, been around for many, many years, and we have a lot of information about it. We have a lot of experience with it. So basically these slides are showing you what the information that's available on the poster and will be available in the booklets. I'm not going to run through all of it today, but it's just there for your information. Warfarin is a vitamin K antagonist. So it suppresses the vitamin K dependent synthesis of coagulation factors in the liver. The tricky thing with warfarin is that we can't be sure that a certain dose will achieve a desired level of anticoagulation. So dose selection is a little tricky and requires monitoring. So we have the International Normalized Ratio, the INR, which is an equation which takes into account the patient's prothrombin time and normal prothrombin time, and it gives us a whole number. So for most patients, we'll be aiming for an INR between 2 and 3. In some instances, it might be a little higher. Another slightly tricky thing with warfarin is that once we achieve our target INR, we can't be sure that it will remain constant. It's subject to fluctuations in terms of other medications a patient might be on, their dietary factors, lifestyle factors. So continuous monitoring is required. So with many patients, they'll need to be attending a warfarin clinic for INR monitoring monthly or 6 weekly once they're in the maintenance phase. The nuisance of this does provide clinicians with, I suppose, a level of comfort in that we can continue to measure the level of anticoagulation. Warfarin is subject to many drug-drug interactions, some of which are pharmacodynamic. So this is constant across all of our anticoagulants, got to do with the medications that have a blood thinning or antiplatelet effect, so to be aware of those. It's also subject to some metabolic interactions, can be a little bit tricky in that sometimes certain medications may increase or decrease the effect of warfarin, but again with INR monitoring we have an idea of the impact of that. An advantage of warfarin is that we have a reversal agent. So administration of vitamin K will reverse the action of our vitamin K antagonist. Moving on to our low molecular weight heparins, both of which are parenteral preparations. Enoxaparin is clexane and tinzaparin is Inahep. Licensed for pretty much similar indications, so mainly the prevention and treatment of VTE, with enoxaparin having a few indications in the cardiology world as well. Generally limited to management of acute VTE, but in our population in the oncology and palliative care world, we do see longer term use of these agents because the dearth of evidence supports their use over warfarin in the prevention of recurrent VTE. Mechanism of action, so they kind of have it's an anti-factor 10A activity. They potentiate the inhibitory effect of antithrombin 3 on factor 10A. Subject to weight-based dosing, so continuous monitoring of weight, well, not continuous, but checking up on the weight is important to make sure that the selected dose is still appropriate in treatment. So our tinzaparin is a unit per kilogram dose and enoxaparin is a milligram per kilogram dose, and as Even said, both are subject to reduced doses in renal impairment, so important to keep an eye on renal function. Similar contraindications and cautions across the anticoagulants. The low molecular weight heparins are less susceptible to drug interactions, so it's the similar ones, the pharmacodynamic, the corticosteroids, or those agents that increase bleeding risk. In terms of monitoring of effect, it's not necessary. We know that the weight-based dosing should achieve the desired level of anticoagulation, but an anti-factor 10A level can be done in certain instances. Maybe there's a suspicion of the risk of bleed, or if we've had patients with maybe recurrent thrombosis on treatment. Caution is advised, though, that the factor 10A levels are done in conjunction with the haematologist because the target levels aren't well validated, so it's not something we do very routinely. And we do have a partial reversal agent with the low molecular weight heparins. Protamine will partially reverse the action of our low molecular weights. Lastly then, the newer agents, so some might call them the NOACs or the DOACs, the novel oral anticoagulants or the direct oral anticoagulants. We have the direct factor 10A inhibitors, apixaban, which is Eliquis, edoxaban, Lixiana, and rivaroxaban, Xarelto. And then there's a direct thrombin inhibitor, which is dabigatran or Pradaxa. We've kind of seen them emerge on the market in the last few years. Of note, they still require HSE approval for funding through the PCRS. So an application form is available on the PCRS website for funding in community, which should be completed by prescribers. When they first emerged on the market, the licensing was in relation to prevention of VTE post-hip and knee replacement, but more recently they emerged with licensing in AFib and treatment and prevention of recurrent VTE. They were heralded as possibly closing warfarin clinics by certain medics, and others, the haematologists, I think nearly collapsed at the idea of that, because there were certain things, I suppose, with them. With the vast history and the background that we have with warfarin, it threw a light on some of the things with these agents that made people a little, I suppose, worried. We no longer have the INR monitoring to kind of know exactly what the coagulation we're at, but we do know that at certain doses these agents will have predictable effect, so it takes away that nuisance of monitoring. Each agent has slightly different dosing recommendations for the indications, and that's available in the information that we've put together. I shan't go through it, but to be aware that, as Even mentioned, there are dose reductions in renal impairment in patients with a low body weight, and also in patients, in older patients. So just to be aware that there are recommendations within each of the products. Then, in terms of, I've mentioned the monitoring. They will have an effect on elevating prothrombin time, INR, and APTT, but this is kind of a transient effect. It's not consistent, and there's a high degree of variability, so it can't be kind of consistently measured to know what effect they're having. So we do have an element of patient trust. I know one of the big issues I saw initially when they came out was cardiologists preparing for cardioversion. If you had a warfarin booklet with 6 weekly INRs showing anticoagulation over the previous 6 weeks, you could be happy that someone was fully anticoagulated. With the newer agents, there is an element of trust and patient compliance. So that's where I suppose patient education and reinforcing the importance of these medications comes in. There have been some DOAC clinics popping up. I think James's have one now. So I suppose that's just highlighting the importance of patient information and education and continued support with these agents. In terms of drug interactions, they are susceptible to drug interactions, a little more predictable. It's got to do with the P-glycoprotein and cytochrome P450 metabolism of these agents. There will be some agents that are recommended to be avoided, things like the ketoconazole, or others that are recommended to be used with caution, like clarithromycin. Again, there is information slightly different for each of the agents, but available in the product literature. In terms of antidotes, so this I suppose is another thing that posed a problem initially when we had a reversal agent for warfarin, and these newer agents didn't have reversal agents at that time. As we mentioned earlier, there is one reversal agent available now for dabigatran. I struggle to pronounce it. Idarusizumab, or Praxibind, and there are reversal agents in development for the other agents, so I suppose they're much anticipated. Of note, the half-lives of these agents are about 12 hours, where with warfarin the half-life is much longer at 40 hours, but the duration of action will be about 24 hours. In terms of bleeding risk from the AFib studies, there was seen to be a reduced risk of major bleed, a reduced risk of intracranial hemorrhage with these agents, but with apixaban and edoxaban, perhaps a slight increased risk of GI bleed. So just bear that in mind. Finally, I suppose the place of these in therapy remains uncertain. The number within our population, in terms of oncology and palliative care, the numbers of patients with active malignancy included in the pivotal trials were low, and direct comparisons with low molecular weight heparins haven't been performed as yet. For the moment, I suppose our message is to be aware of these agents, to recognise them, to know that they are anticoagulants, to know that they may be susceptible to dose reductions in certain populations, and to be aware of the potential for drug-drug interactions. Thank you.
Thanks, Kira. So me again, and I'm going to cover some of the VTE stuff now. So here I'm just kind of running through what's on the guidance essentially, and this is reference to those 3 guidelines that I would have outlined. So when somebody has an acute VTE event, so that's a DVT or a PE, do they have cancer or are they non-cancer? We'll go down the cancer side first of all. They should be on low molecular weight heparin. That's the quiz answer. That's what's advised by and large, okay? Sorry. Next thing to look at is their platelets. If their platelets, they can be as low as 51 and still be okay for full dose low molecular weight heparin. So, you know, that's worth knowing, but that's something that you'd look at. If the platelets are low, then between 20 and 50 they'd go to a half dose, and less than 20 do not anticoagulate. So that's the guidance on it. This little caveat is in just, there will be, possibly not in our hospice population, but there will be certain patients that you might be transfusing them pools of platelets to keep them up, but you know, so it's just to be conscious that that's there. Okay, in the non-cancer population, at the current time, the advice is towards the DOACs. There's a little bit of disagreement in the 3 guidelines in who favours what, I think, but essentially they would tend to prefer, and you see here, even despite our best efforts, we kept flipping between NOACs and DOACs, so they are the same thing. I mean warfarin by vitamin K antagonist there, and low molecular weight heparin. So essentially for a non-cancer patient who has a COT, they're looking for DOACs in preference, then warfarin, and then low molecular weight heparin. So only earlier this week on the ward we had a patient who was diagnosed non-malignant with a PE in December, has subsequently been diagnosed with motor neuron disease and is now quite debilitated and is now a palliative care patient. So again, that was a little bit of thinking as to actually now the DOAC is probably not the best thing for you. You're in an inpatient unit and our preference is to switch you to low molecular weight heparin. So there you go. This is on the poster, which really contains more of the detail, and as I said, go to those 3 if you want. So assessment and education, that's everything that even was talking about in terms of periodically assessing, at points of care. So how long should a patient be treated for? Again, even has been through some of this, that essentially it is 6 months, but indefinitely thereafter. And the language that they use is select patients with active cancer, such as those with metastatic disease or those receiving chemotherapy. So that's our patients. This decision is balanced against risk of bleeding, cost of therapy, quality of life, life expectancy, and patient preference. But by and large, they're on their low molecular weight heparin, and it's expected to continue for indefinite duration in our patient population. What are your other choices? The guidance would say that warfarin is an acceptable alternative, but with all that comes with. The use of DOACs for either prevention or treatment is not recommended by ASCO. Okay, ASCO being the American Society of Clinical Oncology, and very much you tend to follow their leads, whereas the CHEST guidelines, which is the respiratory physicians, and I think it's more of a European paper, they were little less push. They don't really have a preference between a DOAC or a warfarin, or even which of the DOACs you'd have. So I suppose we're just putting it out there that that's your evidence. I'd be going low molecular weight first line, and I would probably be myself following ASCO more than CHEST, but you wouldn't be wrong. Okay. We just picked out selected bits from the papers that we thought would be relevant. So people worry about patients with brain mets, can they be on their anticoagulant? And essentially the evidence base is limited, but the evidence is there to support the use of anticoagulants in patients with primary or metastatic brain tumours who develop clots. Okay, but on the flip side, they are relatively contraindicated in patients with hemorrhagic intracranial lesions, and then we're prompting you there, the brain mets that tend to be hemorrhagic are melanoma, choriocarcinoma, thyroid, renal cell. Okay, so just to balance that up. Kira's covered a fair amount of this around the renal impairment, so just to say that certainly needs to be on your horizon. And based on consensus, an incidental finding of a P or a DVT on routine staging should be treated in exactly the same manner as a symptomatic VTE, okay? But then more detailed splanchnic or visceral vein thrombi, case by case basis, okay? But essentially, if a clot is picked up routinely, it should be treated in the same manner, okay? And then the next question that we just ran through is, if somebody has a clot, is on anticoagulant therapy, and then gets another clot, what do you do? First of all, exclude heparin-induced thrombocytopenia non-compliance. Is the patient actually getting their injections, or is there an actual compression thing there that needs stenting or a whole other phase of management? So for the most part, by the time you look into it, you'd find that they're in fact maybe subtherapeutically dosed in terms of their weight, or maybe their renal functions change. So it's just to run through all of that again and ensure that they're on the full dose for themselves. If they actually are on a therapeutic dose, if they happen to still be on warfarin, you would change them to low molecular weight heparin. If they're on a low molecular weight heparin, the quiz answer is increase the dose, in fact, okay, by 20 to 25%. And ordinarily we're just giving you a little nudge here as to what we'd advise here in OLH is typically to convert to Clexane 1 milligram per kilogram BD subcutaneously, reassess clinically in a week. If they're good, great. If they're not, you're escalating to seek specialist advice. And that's usually a medic calling somebody from the coag team for advice, or discussing with hematology. IVC filters, sorry, I know this is a little hazy, but actually all of the papers, IVC filters are really not supported very much at all. So they very much are saying that they are restricted to patients with acute clots who have contraindications, severe contraindications to anticoagulation, can be considered as an adjunct in those who are progressing despite optimal therapy. But really they're not your fix-all. And I suppose we're seeing that in practice really. We hear about them and see them in our patients very much less. But just a little line on that. I'm not going to run through this, but essentially it's on the table as well. If you're, what are my contraindications, absolute and relative. But essentially this first paragraph here is really what you're focusing on. And it's, as ever, that delicate balance, around life expectancy, risk of bleeding, patient characteristics and their own values, adherence, their ability to get in and out of warfarin clinics, if they're on warfarin, the ability for who's going to give them injections. So there really isn't definite guidance, but you're so well educated now from all of this that you'll be well able to find your way through it. Stephen.
It's a good turnout this morning, isn't it? I found the quiz very difficult. I didn't set the questions. If you got them all right, you did not need to get out of bed this morning. No. Okay, so that's the bit we're doing. Okay, so I think a lot of what we've discussed this morning is a little bit akin to knowing about chemotherapy. We don't need to know the fine print, the ins and outs of chemotherapy. We don't need to know, the details the oncologists need to know. But we need to have an overview. We need to know where it interacts with our patient population. We don't need to know the answer, but maybe we need to know who to ask the answer of. And I think it's a bit similar to the anticoagulants here. If a patient on an anticoagulant starts bleeding in our patient population, and if that's a problem that needs to be treated and that it should be treated, a lot of the time that's going to be referred to the hospital. So those of you who were able to speed read all of Kira's slides will have seen for each of them the antidote or reversal agents to the DOACs or the NOACs. And the answer is that for these newer drugs, we don't have a tidy reversal agent. Some of them you can do nothing. Some of them you may get benefit from hemodialysis. There is an unpronounceable antidote to the dabigatran, I think it is. But we don't need to know those details. We just need to know that there are options. If we have a patient on one of those who's bleeding, that's an acute hospital issue if it needs to be addressed. Other than that, it's common sense, I suppose. I think where a lot of this started was the DOACs. They don't have an easily recognizable name. So I think it's going to be easier for us to miss that somebody is on one of these new drugs. So we need to know the names, need to know it's a little bit more significant. If they're coughing up, if they have a little bit of hemoptysis and they're on one of these medications, that's something we need to think about. So it's knowing the names, and if there's bleeding, it's common sense and probably talking to our acute hospital colleagues. So I'm not going to go through that in detail. This one I just wanted to mention because I think this is something that we would address and that does come up. We still see a lot of patients on warfarin. I think that will fade as the time goes by, but for the moment we still see plenty of patients on warfarin. We do see patients with high INRs for all the obvious reasons. We're putting them on lots of medications. They may be skipping their monitoring. There's things going on that can make their warfarin fluctuate. Now, as has been mentioned, there may be many of those patients, and it is appropriate for them to come off warfarin, and maybe that's not replaced, or maybe to come off warfarin and go to a low molecular weight. But we will still have patients perhaps at that first assessment who are on warfarin, and we may get an INR that comes back high. And I think this is lifted out of the TALA formulary, and I can't tell you unbiased view now, but the TALA formulary is terrific. It's extremely good. You can get it on your phone. It's on the desktops here in-house. It's very useful. It has great accessible information, and just that's what it has on warfarin. And I think it's worth looking at those numbers and knowing if an INR is up, what do you do? When do you do nothing? When do you give some vitamin K? When do you do something in a hurry? Again, it's very simply laid out, so it's worth being aware of that. I think this is really tricky. So, thrombo prophylaxis, if you walk into hospital and you're not a member of staff or a visitor, you're going to be given Clexane. If you come into the hospice, you hardly ever get Clexane. We're not right in our practice on this. We hardly ever give thromboprophylaxis, and that's too low. There should be more patients, I'm sure of it, in our population who get thromboprophylaxis. But how many? We really don't know, and there's a lot of unanswered questions about this. For the acute hospital population, there's a big survival benefit to getting your prophylactic Clexane. We don't know what that number is in our patient population, so there's a little bit of guesswork here. I'm not going to go into it now, but a study that's just come out in the last 2 weeks, it's been e-published, is a big study looking at 1,200 patients followed from admission to a hospice in France, one of 22 centres, and followed till death or for 3 months. And they looked at the risk of bleeding in that population. It's the biggest study done looking at bleeding in our population. And 10% of patients had a clinically significant bleed during follow-up. 10% is very high. So our patient population are at higher risk of bleeding, and thus it is less likely that your prophylactic Clexane is going to be relevant. So when should we be thinking about it? Well, they keep talking about people who have a temporary elevation of risk. So our patient who comes in with high risk, and there's a good chance that risk should come down again, we should think about giving them Clexane. The patient who comes in with high risk and that risk is never coming down, that's not somebody we should give Clexane to. That's an oversimplification, but it's a good starting point to look at it like that. Specifically, it's recommended that patients coming in for end-of-life care or those who are medically stable, so our respite patients who should be medically stable, we shouldn't be giving them Clexane, because in theory they should be up and about just as much as they are at home. For the patient who's coming in and we don't expect them to go home again, the presumption is there that they're high risk and the risk isn't going to come down, and thus we shouldn't give them Clexane. What is the percentage of our admissions who should be on Clexane? We don't know what it is. It's extremely likely to be less than 10%. The largest study done on this was a group in Birmingham. They looked at 300 patients. They reckoned it was 3.4% of their population should get Clexane on coming in. So 1 in 30 or thereabouts. And it really is, because so much of this is unknown, it's a very individualized assessment. So we need to ask ourselves the question, we need to think about this more, but unfortunately, for the moment, there isn't a clear black and white line on this one in terms of what to do. And I suppose the problem is that all our patients have loads of risk factors for VTE. So the various scores that they do to stratify your risk of clotting, and you're already in the high risk group if you have an active cancer. And active means that it's metastatic or you're on treatment. So that's 90% of our patients straight away. If you've had a clot before, how many of our patients have had clots? A lot of them have. If you're over 60, that puts you in a high risk group. Our average age is 69. Dehydration, very common. Immobile, pretty much everybody. Chronic respiratory or cardiac disease, or an acute infection. So if you don't have risk factors, you probably shouldn't have been admitted in the first place to the hospice. So all our patients are at high risk, so the stratifying of risk perhaps isn't that helpful. The contraindications are fairly obvious, and as Lucy had on one of the previous scans, those are fairly obvious, I think. And then it's worth thinking about, you know, if we do decide to treat prophylactically, how do you do that? Well, it's fairly simple. It is Clexane. It's one of two doses. It's 40 or 20. Quite a lot of our patients, it would be the lower dose, because you see the weights they quote there. If you're less than 45 as a woman or 67 kg as a man, it should probably be the lower dose. A lot of our patients are at those weights. It's worth remembering that you don't just go on the Clexane and then forget about it. We need to watch your platelets. So we need to look at your platelets before you start, and we need to check your platelets twice a week is the recommended frequency. So that's a frequency we probably don't normally practice. So are we okay with that? Is that appropriate? Just to hop back for a moment, I suppose when this is being debated, one of the big things was, well, would this be unacceptable to patients to have the once daily injection? Simon Noble is a guy in Wales who's looked at this and has done a fairly nice study looking at this, which shows, I think, quite clearly that patients are okay with getting their Clexane injection. Generally, they're very used to a hospital, and generally, if they feel that this will be something that might bring them benefit, they're good with it. So I think some of the reticence about imposing on patients is maybe ours rather than the patients. And TED stockings. We don't recommend use of TED stockings for fashion or other reasons. Okay, thank you.
So that's it. We've covered most of the guidance. The main thing I want to bring you back to is the big pink bit in the centre. That's if in doubt as to how best to manage the patient, please talk to the consultant or to whoever's around, to whoever you should be around. And as Stephen mentioned, refer to the telehospital medicines guidance. And I have it on my phone, and I believe everybody should have it on a phone, particularly if you have a work phone, and Adon in IT will help you with it. There's an agreement with Tala, it's free or a small fee or something like that, but essentially get it sorted and get it on your phone, and you have access to any amount of advice on anticoagulation and otherwise. It is on the pharmacy page on the intranet, if you can see that there. So intranet, pharmacy, and then scroll down these ones on the right, and you'll find it there, and you just click in and there's off you go. So it should absolutely be your go-to place. The stickers, as we said, you'll start seeing on the wards, and just if a patient's on it, stick the sticker on. You know, it's better to have a sticker on somebody who's on one and they come off it than not on one, you know, vice versa. So we'll feel our way through that. and then the moment you've all been waiting for, obviously. But so just you have a sense of this. This is really the what Even was talking to us about. So it's just that you need to be looking at them. What's their performance status? Are they getting in and out of their Warfarin clinic? Are they at risk of falls? What's their most recent scan reports? Is there now new concerns that would make them at higher risk of bleeding? And indeed, have they actually been having bleeding? Is there anything to see or to be aware of on the examination? And then the investigations that we talked through. So not all of the time, but just run through them in your head and decide if they're appropriate. So a coagulation screen, an FBC, renal and liver would tend to be the main ones. So again, I'll give you a few minutes just to remember these. So the DOACs, 2 of them are not, and then what's the reversal possibilities in a patient on a DOAC. So Tridoxaban I entirely made up myself, and Tinzaparin is of course a low molecular weight heparin. Then you also need to, I suppose, recognise the trade names as well, as should be all of our practice, to stick to the actual name, not the trade name. And what I didn't have up there is dabigatran, which is also under that category. So essentially, the main thing we want you to remember is that there's no reversal agent, available, but there is actually for dabigatran something there. But as Stephen says, not a tidy fit. Around VTE, our patient with cancer has an acute PE, and he should he? I put that on the wrong one. I was cutting and pasting the circles. Clearly that's low molecular weight heparin is what he should be on. He's anticoagulated. 3 months later he gets a second clot, and this was news to me. So it's actually a 20 to 25% increase in your doses. What should happen there? Do you know how long he should be treated for? Indefinite duration, 6 months at least, and indefinite as in until the balance swings the other way for most of our patient population. If you can't have a low molecular weight heparin, what's best? So remember, Warfarin is a reasonable alternative, and then that there's a little bit of discussion between the two guidance, between a DOAC or Warfarin. Is low molecular weight heparin treatment safe in a patient with brain metastases? Yes, but be aware of those that are more likely to be hemorrhagic, and then look at that. If a clot is found incidentally, do you treat it? Yes, you do. And that's where it goes through all of that. So that's our guidance. I hope you found that helpful. The main thing is just to have more of an awareness. The posters, we hope, will be of use to you there. The booklet, as I said, we haven't quite worked through that. We might have sort of one in the main ward areas, but really I'm going to just have that PDF and on the pharmacy page as well. But really it's to point to yourselves to the TALA guidance, to pick up the phone and talk to somebody, and to use your stickers. Get the TALA app on your phone. You should also probably have the up-to-date app on all of the medical phones, and any of you that are around and about.